I get to introduce to you Dr. Kathy Collins-Falea. I'm Tanya Nicholson, the Associate Dean of Midwifery and Women's Health at Frontier, and my friend Kathy is here to present to us. She is a course faculty member for Frontier Nursing University. Her basic nursing and midwifery education was in England, and after returning to this country, she opened an in-hospital birthing center in Detroit at a time when only 5 other CNMs were practicing in the state. After 10 years, she joined the Henry Ford Health System, where she started a new practice with 6 other CNMs. Over the years, Kathy grew this practice into one of the most respected in the state, leading 22 midwives, delivering at 2 hospitals, and practicing in 12 outpatient centers. She has published on clinical as well as practice issues and has spoken nationally and internationally on a variety of topics. And just in case you didn't know, she is the incoming president of the American College of Nurse-Midwives after our own Dr. Sue Stone has completed her tenure there. So we're pleased to have Kathy with us tonight. Dr. Falea, take it away.
Thank you. So today we're going to be talking about how the team works effectively together to solve problems. And what I want to go over with you is how to identify your problem, finding out what causes the problem, looking at what you're really trying to accomplish, and how you can actually fix what you're trying to accomplish or what your problem is. And then looking at how do we find out if it worked or if it didn't work and what you should do next. As an example, I'm going to use Henry Ford Hospital in Detroit, Michigan, where I work. It's a 5-bed obstetrical triage unit with approximately over almost 7,000 triage visits a year. And there's a variety of ages and ethnicity and gestational age, as well as gravity of the women who present to this triage. We have 28 nurses who work there, 12 midwives, 8 residents, and 5 OB techs. So that gives you a little bit of a context as we look at what was the problem. Why did we want to look at the obstetrical triage? Well, nobody liked working in triage. They said that there was long wait times, that patients were dumped in from the clinic. You know, at 4 o'clock, you can predict that there's going to be this onslaught of patients coming in. A lot of non-emergency complaints. The beds get over full. You know there's patients waiting out to come in, and that gives you some anxiety. The provider staff that cover triage also cover labor and delivery, and of course, a baby being delivered tends to be the priority. And there's not really enough nursing staff to staff the beds according to A1 guidelines. So a lot of reasons why people weren't happy. And that's the first thing that you want to look at with a quality improvement project, or to try and figure out what your problems are, is to look, where is the gap? Now we know that OB triage is like an emergency room. There's very unpredictable volumes, and this can impact the time and evaluation of patients, cause long wait times, and then longer lengths of stay. And then that then leads to patient dissatisfaction, staff dissatisfaction, adverse clinical outcomes, and increased cost. So there's many reasons why we really felt that we needed to try and solve this problem. As we started to look at the problem, one of the things you need to do is to get your whole team together, get everybody involved with trying to figure out what the problem is and figure out what you can do to solve it. What we did is look back 6 months beforehand at some of the data that we had to see, did we really have a problem? Because you can't fix something that's not broken. So there was a wait time of approximately, on average, 26 minutes waiting out in the reception area before you even came into triage. But this ranged up to 326 minutes at times that we really had a backlog. Only 70% of the time were the vital signs taken within 15 minutes of arriving in the triage room. That didn't even account for that average of 26 minutes waiting beforehand. The average length of stay in triage was 201 minutes. And we found that arrival to provider evaluation time was about 48 minutes. And it took about 85 minutes to get test results back. There was a negative correlation between patient satisfaction and length of stay, of course, and the team satisfaction was only 68%. So we really had gaps. And that's the first step in a quality improvement project or are using the quality improvement process is looking at where are the gaps. And the plan, do, study, act cycle is a process where you can look at what you're wanting to improve. You plan is you look for the gaps, and you look then into the literature and say, what is best practice? What do the best do to try and reduce these gaps? And then you identify measures to be able to test that. And then the do is you make some changes. You change whatever the current process is, trying to improve it. You study that change to see if you actually made a difference or not, and evaluate the effectiveness of your change. And then you act to change it again if you need to, or to hardwire the process if you really achieve excellent results. So this is a very, very good way of trying to make improvements in clinical practice in a way that the whole team can participate. This is a look at our team. The best team is a very diverse team. Anyone who is involved with the process in some way that you're trying to fix should be on your team. In this picture, there are registered nurses, a nursing IT person who has done all the statistics for the unit, resident, nursing management, an obstetrical technician, the scrub tech, the midwives, a physician, and then on the phone, the receptionist, who couldn't leave the front desk at the time, as well as another midwife. So everyone who touches triage had a role on the team and had a voice in how we were trying to make these improvements. And that's absolutely key for getting engagement from all of the different areas and from the whole team, as well as making sure that you know or you have the knowledge of what the current processes are. One of the first things the team did was sit down and do a causal analysis to really look at what was causing our delays in care. We divided this up into a number of areas to make sure that we covered every possibility. What's highlighted here are the ones that we felt were important enough and we could do something about, because some of the things you can't do anything about, and you're going to waste your time spinning your wheels trying to deal with that. So the long wait time for lab results, we felt we could do something with that, that there's no place for prolonged monitoring of patients, no beds on the unit to transfer a patient to at times. The RNs were just too busy to be able to complete their orders because there wasn't enough RN staff. Unable to staff 2 RNs for 5 beds, which was the standard should have been 2 RNs. There's no algorithm for nurse standing orders so that they can actually initiate some of the care before the provider sees the patient. The provider is not paying attention to the census in triage because they're paying attention to what's going on the labor floor. So they don't know when they need to come and help. And then non-urgent complaints taking up the beds. So the team looked at all of these high-level problems and tried to decide what could we do to close these gaps in care. We looked to the available knowledge. So we wanted to look for best practices. We know that nurse-driven orders reduce lengths of stay in the emergency department. The Ridazar et al. Has been able to reduce the length of stay by 18% or almost a whole hour by using nurse-driven orders. In the literature, standing orders are used interchangeably with the word nurse-driven orders. And there was a study by Haxton and Fahey that looked at women coming into triage not in labor, into OB triage not in labor, and they were able to reduce the length of stay by almost an hour and a half using these standing orders. We also know that if we can reduce the number of patients coming into triage, we won't have some of the backlogs. And we know that patient decision tools help facilitate learning for patients, and then they can make a better decision of whether they should be coming to triage or not. And poor interdisciplinary communication causes delays. So if we can do something about the interdisciplinary communication, that can help impact our delays in care. One of the things that we needed to do was to think about Why are we doing this? Why do we even want to do this other than people weren't happy in triage? Well, the Institutes of Medicine produced 6 aims for improving care. And one of these aims is timely care. And timely care was defined as reducing waits and sometimes harmful delays for both those who receive and those who give care. We also know that the Emergency Medical Treatment and Active Labor Act requires any institution that accepts Medicaid, Medicare funding to perform timely medical screening exams. This covers labor and delivery triage also, as well as the emergency room. And timely medical screening exam is generally held to be about 15 minutes. And this can be just the nurse evaluating the patient, but they have to have some kind of an evaluation. And there's some fairly stiff fines if you don't follow up with this timely medical screening exam, with fines up to $250,000 per hospital or up to $50,000 per individual incident. So that's a pretty hefty fine. We also know if to improve throughput, we need more beds, or we need available beds. We can get this by increasing the number of beds and the staff we have, by decreasing the number of patients, or by decreasing length of stay. We know that nurse-driven orders will decrease evaluation to decision time for patients, and patient decision tools should help to decrease the volume by helping the patient make a better decision about whether they should come in or not. And improving communication within the team will improve the efficiency. So we put all of that together to come up with a specific aim for our project, which was to decrease the length of stay of obstetrical triage patients by 20% over an 8-week period through the utilization of nurse-driven orders, improved communication, and patient engagement. Those were the 3 things that we found in the literature would help decrease our length of stay. This is, I know, a very busy slide, but this looks at the interventions that were done in 4 areas of patient engagement, nurse-driven orders, an algorithm for hypertensive patients, and team engagement. And we actually used 4 PDSA cycles, that Plan, Do, Study, Act cycles. And each cycle had an intervention related to each of these areas of focus. We're going to go through each of those now to show you how that works. So for patient engagement, the first step, or the first cycle, was that we developed a shared decision-making tool called When to Come to Triage, and shared that with the patients and asked them, do you think this would be helpful for your next time into triage? Would it help you with the decision? Well, we got some feedback from the patients, and so for the next cycle, we revised the tool so that it was a little more focused for them based on what the patients told us. So this is the study piece, and then we acted to revise the tool. We found that the nurses were sometimes forgetting to use the tool because it wasn't readily available. So we placed the tool on a clipboard for the next cycle, hoping that that would help increase utilization. It still was being forgotten at times, so that might not have been our best intervention, but you don't know that until you try it and study it and then decide if it worked or not. So the next change was that we attached a tool to the registration paperwork. And this really seemed to make a difference because it was right there with the patient, readily available for the nurse to use. This slide just shows the patient engagement tool, When Should I Come to Triage, which the first version, and then the second version after we clarified with the patients what they thought would be easier for them to understand. For the nurse-driven orders, we piloted orders for evaluation of hypertensive patients because we needed to focus in one diagnosis area rather than just every patient that comes into triage. And we created an algorithm to follow with that. And in the second change, we revised the algorithm so it was clearer for understanding of the nurse's understanding and clarified exactly which order they used in the computer. For the next test of change, we redefined timely orders to 15 minutes from blood pressure to order, and it could be anyone ordered that. So if by chance the provider was there and the provider ordered it, that still was acceptable as timely ordering of the orders. And it was still forgotten sometimes. So the next change was to remind the patient or remind the staff by putting a poster right at the bedside to remind them to order within 15 minutes. This was the algorithm that was used. I know it's very small to see, but you get the concept that there were steps in the process that the nurse needed to follow. So then we looked at right care, and right care was that the patient had the blood pressure within 15 minutes or vital signs within 15 minutes of arriving in triage. Patients with elevated blood pressures or patients who were sent from the clinic for evaluation of elevated blood pressure had their blood pressure cycled every 15 minutes. If the blood pressure was elevated, they had the nurse-driven orders sent. If the blood pressure was in the severe range, there was immediate SBAR call to a provider to come immediately to the bedside to evaluate the patient. In the first PDSI cycle, the charts were audited for compliance. In the second cycle, the RNs track the hypertensive patients manually. So because we expanded to a larger number of patients and it was not possible to have one person audit every chart that came in. That still wasn't the best option for identifying the chart. So we tried to look at using the electronic record. And when we actually looked at that, there was many errors in the electronic record as far as length of stay, because the patients, if they were admitted to a antepartum unit, their length of stay in triage appeared to include all of that. So you had patients that looked like they might have been there 4 days and then discharged out when they actually had been moved to the antepartum unit. So we actually had to go back to a length of stay being manually checked for compliance. As far as the team, which is, again, the most critical piece of this project and with any project, making sure your team is engaged. We began with weekly huddles of identifying for the team what our focus was, what we were trying to achieve, how successful we've been, and what the next step would be. We focused in the second cycle on improving communication, because the feedback that we had received from the team was that the nurses and the providers weren't really communicating well when orders needed to be written or orders it needed to be implemented. We had a special phone that we gave to the nurse and to the provider to use. This didn't work as well as we had hoped it to work, mainly because if the resident was there, the resident had to leave, go back up to the front desk, and ask the attending. So we tried to implement a flag system when placing orders so that the resident could just flip the flag when they left the room. And the nurse, if she was busy, as soon as she was finished, she could see that this flag was there. That didn't really work again either, because the residents were going back up to the labor and delivery unit before they knew whether they would be ordering anything or not. So the last intervention we tried to see if we could make a difference with was initiating clinical huddles after a patient had been in triage for 2 hours. So that at 2 hours, the nurse calls the provider and says, the patient has been here 2 hours. What is our plan? What are we waiting for? What do we want to do? And then a decision was made. So this slide looks at the measures that were used to see if our interventions were effective or not. Every focus area has a process measure and an outcome measure. For the team, the process measure was the percentage of huddles that used a checklist to make sure that all the topics were covered during the huddle. And the outcome was the mean job satisfaction scores for the staff to see if we were improving their job satisfaction. For patient engagement, the process measure was the percentage of patients who used the tool when to come to triage. And the outcome measure was whether they were satisfied with the tool, whether the tool helped them felt that it would help them to make a decision of when to come or not. For the nurse-driven orders, the process measure was a percentage of patients that had the nurse-driven orders initiated. And the outcome measure was the mean time from admission to discharge to see if we actually were shortening that length of stay. The compliance with the hypertension algorithm was a percentage of charts that were audited. This would have been the percentage of hypertensive charts that were audited. And the outcome measure was a percentage of patients who received the appropriate care. Now, whenever you do these kind of big changes, you need to look at if there's anything that you're accidentally adversely affecting. That's called a balancing measure. And one of the balancing measure that we looked at was the job satisfaction for the different job categories. So that we had RNs, midwives, OB techs, and OB residents. And we wanted to see if one category improved versus another decreasing, or if we were adversely affecting anyone, because we were changing in some ways how people were working with each other. So the outcomes show that we achieved most of our goals, that we were able to decrease the overall length of stay in triage by 46 minutes or 23%, that the team engagement increased from 68% to 80%. The patient engagement, we were not able to get as high a utilization of the tool as possible, and we'll talk in a minute about why that was. But the patients were very satisfied with the tool. The nurse-driven orders were used 91% of the time, but we were not able to decrease the length of stay as much as we had hoped. And again, we'll talk about that in a minute. Charts that had the hypertension algorithm used were 100% compliant, and all of the job satisfaction scores increased for everyone in the department. This graph looks at the overall aim, and I know it's a very busy graph and a little hard to see. In blue is the length of stay for all patients, and that actually we were able to decrease that length of stay, like I said, 23%. The green length of stay was just the one for the hypertensive patients, and we were only able to decrease that by 18%. Excuse me, by 9%. The reason for this was that, and you can see these outlier astronomical points here, some physicians still, even with the patient meeting all the criteria for discharge, were still hesitant about discharging them. They wanted to watch them a little longer. Maybe that something would change. Or they were hesitant to make the decision to admit them to watch them longer because maybe we would take up beds that we need for something else. So it actually was a practice pattern issue rather than not having the vital or the lab results available, which is what we had thought it would be from the beginning. Patient engagement, as far as utilization of the patient decision tool, this was running very well until at one point when the nurses thought we did not have to use the evaluation tool any longer. And the evaluation tool was used as a proxy for whether the patient was actually given the tool or not. So the satisfaction tool wasn't used, so we had no way of determining whether the tool itself was used. The nurses felt that, yes, they did use the tool, but the data shows that we had a dip. However, by the end, we were able to come up to the 80%. Compliance with the hypertension algorithm was pretty well consistent with the median at 100%. Occasionally, the nurses didn't feel, or a particular nurse didn't feel that the blood pressure met criteria when it really did. And that's why we have a few outliers. The team engagement, this was interesting because this was also involved the balancing measure. So the mean team engagement for the team increased. That's this dark blue line. And each of the individual job types have their own line. Of interest, the midwives, who were very low down at about 43% when we started, their line consistently went up to about 83%. The residents was also very interesting. They started with an increase and then all of a sudden had this big dip. And this is because This was a new month, and the residents switch at a new month, and it was at the time we had new interns on the unit. So the first day on as a OB resident on labor and delivery, after 2 weeks, we're asking him, so how do you feel? Do you think that the changes in triage helped you? Do you think? So they had a very hard time with just everything. So of course their satisfaction was way down. However, we work with them as a team to support them and to communicate better. And we were able to show that change and increased up to the top again. The purple is the OB tech. And the reason that this took a dip is the OB tech thought that they were answering for how they thought other people would feel. And they knew that the residents were stressed. So that's why they had a dip. Once we were able to identify that and clarify that this was how they felt, not how they thought someone else felt, they increased also. So as far as a summary of the key findings, the overall length of stay decreased by 46 minutes, which is better than the goal. The hypertensive cohort length of stay decreased by 17 minutes, which was below the goal. The staff satisfaction increased by 12% overall. The midwives increased by 40%. All job classifications at the end were at or above 80%, except for the OB techs. Patient decision tool satisfaction was 87%, 100% compliance with the algorithm, and we decreased the mean time from arrival to test results by 49 minutes. So the strength of this project show the importance of team engagement. You cannot really make any changes on a unit in a practice without everyone being involved. People have to have a voice in how the project is designed. They have to understand the reason behind the project and what you're trying to accomplish, and they have to understand their role in the project. Lucky at Henry Ford, we have a unit culture of continuous quality improvement and collaboration. So we really were set well to have everyone involved with the project. There's minimum costs involved with this. And it really increased the autonomy of the triage nurse, which they greatly appreciated. And it put more hands in the, more data in the hands of the provider at the time of initial evaluation of the patient. The anticipated decrease in length of stay wasn't demonstrated to the fullest extent described in the literature, and this is because it was very reliant on provider preference more than not having the test results, which the literature assumes that delays are caused by waiting for test results, and this really wasn't the case. It was just a provider preference. The focus on communication and being conscious of overall length of stay had a very strong influence on the length of stay of everyone in triage, rather not just those hypertensive patients. The surveys and huddles really helped the staff to have a voice and feel like they were part of the process. When to Come to Triage tool has a great potential to be used in the outpatient setting as well as the inpatient setting to help patients with their decision making. There is limitations here. The practice patterns are very specific maybe to Henry Ford. They may not be the same at other places. You may not have the same staffing model with midwives and residents, staffing triage, and you may not have the same staff engagement that we had at Henry Ford. So in conclusion, we made significant impact on triage throughput. Less crowding decreases the risk of error, improves satisfaction, and decreases the workload. It's very sustainable as long as you're willing to facilitate a timely disposition. People have to want to move patients through triage in a timely fashion. So for the next steps for this project, a formal policy for nurse-driven orders and the electronic medical record order set was initiated. We transitioned the When to Come to Triage to a team that was looking at education for the outpatient setting. And we need to continue focus on communication and trying to move patients through. And we can spread to the other hospitals in our system easily the concept of the nurse-driven orders to help facilitate patient transport. This is just in summary, a picture of the team. And again, the team is what made the project successful. If you don't have the team involved, you're not going to be able to move through. And the team involves everyone. It involves constant discussions and working together. So thank you very much for listening.